everyone, I am Dr. Gargi from Department of Oral and Maxillofacial Pathology, Narsibhai Patel Dental College and Hospital from Sakarchand Patel University. Today I am discussing about the non-odontogenic tumor of oral cavity. Okay, let's start. So these are the basic terms, tumor and neoplasm. So tumor is defined as simply a swelling of a tissue. In the secret sense, the word does not imply a neoplastic process. Okay, it's simply a swelling of a tissue which is named as a tumor. Whereas neoplasm, on the other hand, can be defined as an abnormal mass of the growth of which extend and uncoordinated with that of the normal tissue and persist in the same excessive manner after cessation of the stimuli which evoke that changes. Okay, so what is the difference between tumor and neoplasm? Both terms are equally used, but the difference is the tumor is just the swelling of any kind of tissue is named as a tumor, which is a broad old clinical term which may be due to inflammation, trauma, cyst or neoplasm. Okay, so in terms of bigger term, the tumor is more wide term than that of the neoplasm, because neoplasm is an abnormal new growth of cells, an abnormal mass of tissue resulting from the uncontrolled, excessive and uncoordinated cell proliferation that persists even after the removal of stimuli. So in case we remove the stimuli, the neoplasm again continues to grow. So it can be benign, pre-malignant or malignant. So neoplasm can be of three types. So main is the second terms are the benign and malignant. So main difference between benign and malignant is the according to the growth rate, it can be slow or rapid. According to the mode of growth, expels or pushes the surrounding tissues, and in the malignant it can be inflammative, invades surrounding tissues. Whereas the capsule usually encapsulated and the malignant are the non-capsulated with the ill-defined margins. In the benign it is well differentiated, whereas in malignant it is poorly differentiated, which may not resembles the tissue of origin also. Okay. So other are the cellularity. In benign it can be of normal. In malignant it is markedly hypercellularity. Whereas in nuclear features, it can be of in benign there are normal nuclei, small and uniform. In malignant it can have these difference in the size and colors, so and the shapes also. So it can be large nuclei, increasing in size, hyperchromatic, which means the increasing in the color of the stain of the nucleus get darker. And the pleomorphism, which means the difference in the shape of the nucleus, or it can be in multinucleated also. And abnormal mitosis, which also result in the multiple numbers of nucleus. Whereas the mitosis in benign there are few normal mitotic figures. In malignant it can be numerous atypical or abnormal mitosis. Recurrence after removal. After the removal of benign tumors, there are rarely it can recur, but in the malignant it is most common to recur as the proliferation of the tissue is more. So other differences are the metastasis. Metastasis means the tissue which are intends to have the growth much more as a neoplasm, which travels through the lymphatic vessels or the blood vessels and proliferate in the other side of the body, which means as the metastasis, which is absent in benign, and in malignant it is present via lymphatics, bloods or CDs. Okay, the effect on patient. Benign it is locally pressure, cosmetic, functional disturbance only, but in malignant it can be systemic effect or the life threatening. So common example for benign are the fibroma, lipoma, and the osteoma, and in malignant it is carcinoma, sarcoma and osteosarcoma. The mnemonics to remember it is easily. So 3S for the benign. There are slow, safe and similar, which means the slow growth, safe, no metastasis, and there is a similarity to the parental tissue. Okay, and whereas in the malignant it can be fast, fatal or foreign looking, which means the fast growing, fatal potential, and the foreign or the atypical cells are present. Okay, so now let's do further with the tumors classification, which can be mainly divided on the basis of the origin of the tissue. There can be odontogenic as well as non-odontogenic tumors. So odontogenic means the tissue which are origin from the tooth, which are consist as a odontogenic tumor, and in the non-odontogenic, which are the tissue which arises from the another tissue except of the odontogenic tissues. Okay, so today we will discuss about the non-odontogenic tumors. Okay, so it is mainly classified into the other origin tissue, which other origin tissues except that of the odontogenic tissues are the epithelial tissue, connective tissue, muscles tissue, then nerve tissue, and the metastatic tumors of jaws. Okay, let's further widen the classification. So all the tissues of the different origin are divided into sub-two divisions, which are benign and malignant, which we have learned earlier. So in benign it consists of the squamous papilloma, then second is the keratoacanthoma, and the third is the oral nevus. Okay, so these are the most common one in benign in epithelial origin. Whereas in malignant, squamous cell carcinoma, basal cell carcinoma, verrucous carcinoma, spindle cell, adenosquamous, basaloid, adenosquamous carcinoma, undifferentiated carcinoma, lymphoepithelial and the transient cells carcinoma, and malignant melanoma. Okay, these are the common. Then the connective tissue, it has the fibroma, lipoma in benign, myxoma, chondroma, benign chondroblastoma, osteoma, osteoma, benign osteoblastoma. And whereas in malignant, most common are the fibrosarcoma, malignant fibrous, histocytoma, synovial sarcoma, liposarcoma, hemangioendothelioma, hemangiopericytoma, Kaposi sarcoma, which is the most IMP one, then the chondrosarcoma, osteosarcoma, non-Hodgkin's lymphoma, primary lymphoma of bone, Burkitt's lymphoma, Hodgkin's lymphoma, multiple myeloma, and plasmacytoma. These are from the connective. Then the muscles origin, which includes the leiomyoma, then angiomyoma, rhambodomyoma, granular cell myoblastoma. Then in malignant it has the three alveolar soft part of sarcoma, rhabdomyosarcoma and leiomyosarcoma. Okay. From nerve tissue origin, it can be from the nerve sheath or the nerve bundles or the nervous tissue. So the neurofibroma, neurolemoma, melanotic neuroectodermal tumor of infancy, and in malignant it has peripheral nerve sheath tumor. Okay. So today we'll learn about the epithelial tumor of epithelial origin, benign tumor of epithelial origin, which is the squamous papilloma, keratoacanthoma, and oral nevus. Today we'll start with the squamous papilloma. So squamous papilloma is benign and mostly induced by the HPV, proliferation of stratified squamous epithelium, or the varicoform mass. Okay, incident are of the one of the every 20 to 30 adults, and 3% of all the oral lesions. There is no sex significance, and the age is from between 30 to 50 years. So these are the clinical images, as you can see. Okay, it is main etiology is the HPV type 6 and 11 are most commonly involved. Okay, so clinical features for squamous papilloma, it is an exophytic growth. Okay, its growth is exophytic, which is the grow above the epithelium. Okay, and finger-like projections. Okay, roughened, verrucous and cauliflower-like appearance. It is well circumscribed, pedunculated tumor, occasionally sessile, painless, whitish to pink in color. Okay. So as you can see, there is a proliferation. Okay. It's like finger-like projections projecting outwards. Okay, this is the projections, and it can be like this also, pinkish in color. Okay, this is the pedunculated lingual mass with the numerous long pointed and wide surface projection or the smaller projections around the base of the lesion. Okay. So most common sites are tongue, lip, buccal mucosa, gingiva, palate, uvula, and the size is few mm in diameter. Okay, so the diameter of the projection, from base, it is of few mm. Okay. So histopathologically, which is most IMP, there are long, thin finger-like projections, which is seen in the slide, extending above surface of the mucosa, continuous layer of stratified squamous epithelia, and containing a thin central connective tissue, which is the core supportive nutritive blood vessels, which is hyperkeratosis, and cheleocytes. Cheleocytes are present in the superficial epithelial layer, which means the altered epithelial cells with the pre-nuclear clear space and the nucleus pyknosis. Okay, so it is there is a nucleus with nuclear clear space. ये वाला space, it will be cleared. Okay. So let's see the histopathological diagram. As you can see, there is a long retinages. So as you can see, there is a thin projections. Okay, it's in the low power, that is in low power magnification. So showing a pedunculated squamous epithelium proliferation, there is a multi-papillary projection with the fibrovascular connective tissue core, which means this is the epithelium present over here. Okay, and these are the, as you can see, there are finger-like projection, and in between this is the connective tissue cord. This is the connective tissue cord. Okay, so this is the pedunculated squamous epithelium. Okay. So this is in the high power. As you can see, this is the tip of the papillary projection. So clinically, where we have seen this thing, so this is projected here, and you can see this is the proliferation. The projection shows the mature stratified squamous epithelium. So this portion is your squamous epithelium with a slightly thickened para-keratin surface layer, and the connective tissue process is covered by the hyperkeratinized stratified squamous epithelium. So differential diagnosis: inflammatory papillary hyperplasia, papillary hyperplasia, varicovulgaris, chondrioma acuminum, varicose xanthoma, and the focal epithelial hyperplasia. So difference between the varicose vulgaris and the squamous papilloma is the numerous papillary projections are covered by the hyperkeratotic stratified squamous epithelium, elongated ratty ridges at the edge of the lesion coverage towards the center. The insert shows the clear polyocytes in the upper epithelial layers. Okay. So in this there is an invasion, okay, there is inward, and in the papillary it is in the outward direction. So treatment: excision includes the base of the mucosa into which the pedicle or the stack inserts. Recurrence are rare in case of the proper excision. Okay, thank you.